So today I will be talking a little bit about hormone replacement therapy. We're going to be addressing nurse practitioners, PAs, physicians, family doctor, internal medicine doctors who see women in this 35 to 50-year-old age group. I think hormone replacement therapy is hugely underutilized. Probably 50% of women could really benefit from it. They will live longer, feel better, have ultimately less problems with osteoporosis, cardiovascular disease, and dementia. We'll get into that in just a minute. I'm going to try to keep this as brief as I can, but I think the most important thing to realize about all this is that about age 40, women do start having some very gradual decline in the output from their ovaries. That decline continues until they're 60, 65, maybe 70, with the point being it's a long period of time from here to not very much. And some women will drop suddenly and trail off, others much later. Either case or any case, at some point, women do drop through a threshold. Most will have some complaints of declining output from the ovaries. So the most common two complaints are the hot flash, night sweat thing, of course, everyone knows that, but they can have mood, depressed, can't think, can't remember, can't come up with words, names, numbers, brain fog, cloudy thinking, can't sleep, go to sleep, can't go back to sleep, usually at 2 or 3 in the morning, hair, thinning and losing luster, the vaginal dryness thing, dyspareunia, pain with intercourse, because of that, decreased libido, fatigue, weight gain. 25 complaints. No one has all 25 things, but one thing or two things. The most common are the hot flash, night sweat thing, of course. So if a hypothetical woman were to say, yeah, so I'm in this age group, and a few months ago or 6 months ago, I was at work, unpleasant hot sensation quickly subsided, woke up at night, sweaty, what is this? It's a pretty good bet she's dropped through the threshold. Therefore, it is a pretty good bet if that level were restored, go away. And if at the same time she says, yeah, so in addition to that, my mood, my depressed, I can't think, brain fog, cloudy thinking, can't sleep, go to sleep, can't go back to sleep, hair, skin, vaginal sexual fatigue, weight gain, all these different things all started about the same time. And it's a pretty good bet it's all related, and you restore where she was here, normal, it will all go away. Not always, in the sense that men have insomnia. I mean, you can't blame everything on this, but a lot of it you can. So there are 3 outputs from the ovaries. There's the estradiol, progesterone, and the testosterone. All of them you can get as human bioidentical hormones. They can, and I'll get to how to deliver them in just a second. But the estrogen component, of course, tends to correlate with hot flash, night sweat thing, but also the mood. The mood has a estrogen component and a testosterone component. The estrogen component is dealing with stuff and not having excessive anxiety. I'll get to the testosterone in a minute. The estrogen affects sleep quality, brain fog, can't come up with words, names, numbers, but this word retrieval thing, short-term memory, the vaginal dryness thing, hair, as again, skinning, luster, and probably weight gain, particularly around the midsection, and fatigue. So the progesterone is declining also. It tends to help with sleep. When a woman is deficient there and you give her the progesterone supplement, you know, they tend to sleep better. And finally, testosterone. Testosterone is a normal output from the ovaries. There are 4 known benefits or uses for the body has for the testosterone. 1, mood, but the mood with testosterone is more, I'm happy about my life, everything's great, tomorrow's going to be a great day, that version of the mood, whereas the estrogen is more the anxiety, the sexual interest, meaning libido, the get up and go, energy, and of course, muscle mass. So all of it is important, and most women, as you go through the menu that I just gave you, will have quite a few of these complaints. So all of it can be supplemented. You can give all of it by mouth, but the problem with that, with the estrogen, if you give it by mouth, the bioidentical molecule, it's degraded in your stomach and further degraded in your liver. So what really gets into your bloodstream is not the same thing. So you can give the bioidentical estradiol through the skin, but it has to go either a cream, a lotion, a patch, injection, pellets. I mean, it has to go through the skin to be the bioidentical thing that gets into a woman's bloodstream. The progesterone, it can be given orally. It needs to be given as prometrium, the natural progesterone. Usually, there are a variety of ways you can give it. What I tend to do, especially if sleep is an issue, is just give 100 milligrams every night at bedtime when she's brushing her teeth or something that she would associate with going to bed. That's when she takes the progesterone. It will help with sleep. The testosterone, let me just briefly say, that can be given a number of different ways. We only give that if there are issues, or primarily that would be the time to give that. So going back to what I just said, there is the sexual interest, there's the mood, there's the get up and go, and the muscle mass. But of those, the one that sticks out most prominently and women would voice would be the decreased libido, diminished libido, flatline, subbasement, however they care to express it. So if that's an issue, a lot of times we'll start off by giving the testosterone shot. If you take the subset of women that would say that, so they're in this age group, 30-ish to mid-40s, even early 50s, and say, yeah, very diminished, flatline, no interest at all. You take that group of women. Okay, you give them the testosterone shot, just like an injection in the backside, and about 2/3, maybe 70%, are going to say, wow, that was pretty good, pretty much back to normal here. No complaints in that department, which is a different way of saying about 30% are going to say, thanks, nice try, but I'm not really sure it helped. So there are other reasons for diminished libido, primarily the SSRI drugs, but they can have fatigue, chronic fatigue syndrome, thyroid issues. I mean, there are lots and lots of other reasons people might have relationship issues, lots of other reasons, but about 2/3 are going to say, wow, that testosterone really helped. That testosterone shot can be repeated every 2 months, 3 months. Again, this is something that if you're interested in finding out more about it, I have several more things about the testosterone I could tell you. The first thing is to find out if it benefits somebody. So if that libido thing is an issue and giving the shot, yeah, that really helped, then that's important information. What you need to realize is a lot of women, of course, have some of these problems. There are some tremendous good things about the hormone replacement therapy and a few things you need to watch out for, very much so, and I'll get to those in just a second. So the good things are women will feel better, for sure. If they're feeling better and more energetic and upbeat and have more energy, that means a lot of the lifestyle things that, of course, are going to be synergistic to make them feel even better than that, healthy eating, nutrition, exercise, it all sort of works together. So they're going to feel better, they're going to therefore have better lifestyle choices, etc. In general, women on hormone replacement therapy live longer. This is not even debatable. They look better. They have the less fat loss, subcutaneous fat loss throughout their body, but especially in the face. Less collagen loss, the hair thing. So in general, the cosmetic, they have a fraction, maybe half the rate of osteoporosis, therefore far fewer hip fractures, wrist fractures in later years, the fewer heart attacks, strokes because of cardiovascular benefits, and finally, a significantly less dementia, Alzheimer's disease. So if a woman especially is saying, yeah, I've got the brain fog thing, yeah, I'm having trouble coming up with words, and I'm here, I'm 42 years old, I'm 48 years old, this is not a brain problem. This is a GYN problem, this is a hormone issue, and you restore the estradiol in about between 95-98% of the women who are saying that in that age group, they're going to have clarity. When she says, yeah, wow, I was having all these cognitive and processing and coming up with words and brain fog thing, hormone replacement therapy, I just don't have it anymore. Her likelihood of eventually developing Alzheimer's or some version of dementia is going to be cut in half or at least by a third if she stays on the hormone replacement therapy. So this has been well documented, and it certainly has been our experience. And if you're interested in finding out more about that, I'd be glad to tell you. There are a couple of downsides, and you need to be aware of this. If a woman is starting to is in this age group, say, let's say early to mid 40s, now her period, she's having a lot of these symptoms, but at least her periods seem to slacking up and less frequent and less flow. Or maybe, yeah, I haven't had a period in 6 months. Okay. If you give hormone replacement therapy, you're going to be stimulating the endometrium. So therefore, you're going to continue the bleeding. And if someone stopped, you're going to, in some women are going to be having de novo, where they haven't had a period in a month, a year or two, and now you're going to have what it would meet the definition of postmenopausal bleeding. In addition to that, and I'm going to digress just a little bit here, the endometrium is what's responsible for the periods, and everybody knows this. So the uterus itself is about the size of a lemon, large lemon, small orange. It has an internal space that is lined by some hormonally active skin called the endometrium. So the endometrium is the portion of the uterus that thickens and sheds and thickens and sheds and goes through the cycle we all know about. As the endometrium degrades and gets ready to shed, it will release a vasoactive neuropeptide into the bloodstream, and that is what triggers the symptoms that women have in that lead up to the period phase or first part. For example, the fluid retention, bloating, the headache, the mood. The mood falls into 6 categories: anxiety, irritable, anger, depressed, emotional, agitated. Yeah. I don't want to talk about it right now. Next week, we can have that conversation. It's this premenstrual mood. About 80% of women have some degree of that, and I'm sure 20 or 30%. It's pretty debilitating, and most women characterize this, at least in our office, I'd say 30% would say it's very disruptive to their life. That is caused by the same vasoactive neuropeptide that is triggering the bloating and the headaches. It will trigger the premenstrual fatigue, pain, the food craving, typically chocolate, salt, sugar, the breast tenderness, the acne, anything, some idiosyncratic things, but anything that occurs right around the time of the period, leading up to the period, first part, that goes away, is not caused or has nothing to do directly with the ovaries. It has to do with the metabolite, the degrading endometrium releasing a vasoactive neuropeptide, triggering all the things I just mentioned. So, getting back to our main subject, hormone replacement therapy, if a woman says, I'm having the cognitive and the sleep and some of these other things and the hot flash, I really think I would benefit from the hormone replacement therapy. And the practitioner says, yeah, this sounds great. We can give you the hormone replacement therapy. She says, yeah, good idea. We'll do that. Let's do it. The practitioner says, well, I just need to tell you one thing. This is going to possibly restart your periods or continue the periods. She says, yeah, but this is like the one thing I'm happy about. Furthermore, in a lot of women, just think what you're doing. You're stimulating the endometrium with the estrogen, and if they have a uterus in place, it is required to give them the progesterone component. It can be given in a number of ways. Frequently, what we do is the 100 milligrams nightly. But regardless, if you have an endometrium and now you're taking the progesterone to degrade it, then you are going to give most of those women the chronic low-grade version of the premenstrual complaints. Now just think about that. So you're swapping one group of symptoms, the cognitive, the sleep, the other things, hot flash, that women might, the vaginal dryness thing, they might have as a consequence of declining estrogen, but then you're swapping it out and now you're continuing the bleeding or maybe making the bleeding heavier, as well as giving them the chronic low-grade premenstrual complaints. Most women usually won't be complaining of that because I think to some degree women are even conditioned not to complain about premenstrual stuff. I mean, every mother tells her daughter, come on, honey, don't complain about stuff like this. And I think there's almost a preconditioned thing I've seen over the years. That doesn't apply if you ask people directly and say, yeah, a lot of women before the period will have such and such and this and this and this. It is surprising. Yeah, I have this and this many days, and it bothers me on a scale of 1 to 10, such and such. 10. Very disruptive. So it's surprising. They don't start off with that, but they come back to that. So if there are two ways to handle this. If someone is having symptoms where you say, yeah, but she's having declining output for ovaries, I think she would be a good candidate for hormone replacement therapy, bioidentical hormone replacement therapy, which is BHRT, commonly referred to. Then you can do that. And I'd say, especially in women who've had a hysterectomy, there's zero problem with that. In women who have not had a hysterectomy, a lot of times they'll do okay, but a fair number are going to say, wow, you're swapping these problems, and here I'm back to having these problems or an enhanced version of those problems. So one option would be to do the endometrial ablation to start with. A lot of times we will, especially in the younger age groups, the 38 to 45s, I'll tell them, look, let's just do the endometrial ablation first and see how you do. And if you say, I feel like $1 million, I'm perfect, don't have any complaints, we're done. We don't need to add hormone replacement to it. If they say, well, it's great not having periods, and the PMDD's gone away, and I don't have the headaches anymore, and the bloating, and the acne, but I'm still having some of the sleep issues, the brain fog, hot flashes, we'll go ahead and give the hormone replacement therapy, and of course the testosterone, I talked about that earlier, usually helps a lot, especially if people need it. So if you are considering doing in your practice or have done hormone replacement therapy, also be aware of a couple of things. Hormone replacement therapy does not cause cancer. This has been absolutely determined with finality. The study, that so-called Women's Health Initiative, has been debunked countless times. If you're interested in Googling it, you can Google debunked theory that estrogen replacement therapy causes cancer or hormone replacement causes cancer. You could look up the Women's Health Initiative, debunked. It's a long story. There's thousands of articles on this on the internet if you're interested. The bottom line is hormone replacement therapy, given in the right way and the right dose, is completely safe. when you think about it, it's almost common sense. I mean, why would a molecule that is in the bloodstream of a child, and now she's a teenager, and a 20s, and a 30s, and now 40s, and it's declining, and she's having some symptoms, and you restore it, the same molecule, I mean, exactly how does this cause cancer? So it's like nonsense. I mean, this never has, and it is, common sense plus medical literature. It is not associated with cancer. Women will do better, feel better, live longer, less dementia, cardiovascular disease, and osteoporosis, etc. However, a couple of things. If a woman has postmenopausal bleeding, then you need to figure out what's causing the bleeding. So by way of example, let's suppose hypothetical woman is 45 years old and not having periods, and you start some bioidentical hormone replacement therapy and she doesn't restart bleeding. But then now she's 48 or 50 and is having some bleeding. This is by definition postmenopausal bleeding. So it is a GYN term of art. It means something. And women who have postmenopausal bleeding, meaning a year or two with no period or bleeding, and now they're bleeding, this is by definition. Is it a year or is it two? That's a judgment call. But if it's been 2 years, this postmenopausal bleeding, this person 100% needs some endometrial sampling. They need sonogram just to be sure everything is normal, and probably either a sampling endometrial biopsy or a DNC. So what's causing it? I mean, probably, I will tell you, there are only two possibilities. One, it is hormonal, which means some thickening of the endometrium. And there's really not a problem with that. That's benign, and it may be a little hyperestrogenic or whatever, but it's just a normal hormonal endometrium. The other possibility is some form of tumor or growth. It could be a benign polyp. Here the artist is trying to show you that. The endometrium just sort of heaps up. Endometrial polyps are, I'd say, at the 99% level, benign. They have nothing to do with, for example, by way of example, colon polyps. These tend to be very benign, not a problem, but you don't know that. And so, again, even if they have some polyps, they need to be sampled and just be sure that's what's going on. There may be some fibroids, some other things that can cause it. But you need to know with finality that this is not cancer or something like that. So if there's postmenopausal bleeding, 100% of those women need to be evaluated. So if you're giving hormone replacement therapy, is wonderful, but you need to have a game plan. And if someone has the postmenopausal bleeding, you need a doctor, a GYN doctor, to help you with that. A lot of women will say, a lot of people who give hormone replacement therapy will simply say, well, gee, I've been giving you this hormone replacement therapy. I mean, who's your regular GYN doctor? And so I say, yeah, but so-and-so delivered my baby, but I haven't seen so-and-so in many, many years. So one of the services that we could offer is to consult directly with you, nurse practitioner, PA, family doctor. If you're giving hormone replacement therapy, we do not charge for this. If you would like to have questions or consultation about this, that is what we do. So but for sure, that person needs some evaluation. And honestly, in the nature of the OBGYN industry is these large practices, about 90% of their income is derived from the obstetrical side. Most of what they're doing is obstetrical. The GYN a lot of times gets short shrift. Here's a lady we haven't seen in a long time, some irregular bleeding. A lot of times she doesn't get the attention that she needs. Be aware of that. If we can help you with that, by all means, let us know. So just, I want to emphasize a few things. The FDA, based on that, well, I was going to say crazy, but I hate to use harsh language, or stupid harsh language, but just a totally inappropriate, wrong-headed women's health initiative. Based on that study, the FDA back in the early 2000s put a so-called black box warning on estrogen replacement therapy. As a consequence of that, millions of women simply went off the hormone replacement therapy altogether. It's caused untold damage, personal damage, various deaths have been calculated. Probably millions of women have died as a consequence of having prematurely earlier than they would have as a consequence of the FDA having done that. There have been studies on that particular subject, which I'd be glad to share with you if you're interested. Finally, in the early spring of 2025, I don't know, it was April, May, something like that, the FDA rescinded that black box warning. And so it's not to say there's not, anybody can have allergic reactions or have problems with something, but they rescinded this idea that it's associated with cancer when given in the right way, in the right dose. So as a consequence of that, there's tremendous interest from family doctors, internal medicine practices, even aesthetic practices, other types of medical practices. And so I think it's highly appropriate. It's going to help women tremendously, but you need some backup on some of these things that I've talked about. If you would like to talk to me about all this, go to our website. I'm Dr. Ashford, Clinton Ashford. You can go to drashford.com. Give us a call. You can speak to one of our nurses if that would be helpful. If you're a physician, PA, nurse practitioner, and would like to speak to me directly, I would love it. That's what I do. There is zero charge. Any way I can help you, you just let me know. So this is Dr. Ashford signing off. I look forward to talking to you, and we'll help any way we can. Thanks.